primary stroke center with the state of New York State Department of Health. We have been reviewing and doing a lot of new modalities or procedures now here at Richmond University, which we have not done before. We do now thrombectomies, which is now considered the new standard from American Heart for somebody who has what we call large vessel occlusion. And we do have a neurointerventionist team now on board with us. So other than our neurology team of doctors, Dr. Burrell, the team of Feldman, Al Schuler, Dr. Hahn as well, and Dr. Asawaka. We also have I think it's a 5 or 6 member team of neurointerventionists that do actually mechanical what we call thrombectomies. They go in and they actually retrieve and take out the clot, prevention of strokes. There still is that time element of window, which is a 60-minute window from when you come to the emergency room of any facility, that you have to be evaluated and assessed to make sure you're a candidate for TPA, which is the clot-busting medication we give you. And then within that same time element, if you don't get TPA, or if you're not a candidate for TPA, you are a candidate to get a mechanical removal of the clot in your brain. Several weeks ago, which you'll see, I might be part of the video as well, we had our first thrombectomy who was here in April. We started opening our doors April 1st, and she had a thrombectomy on April 6th. And from the minute, as soon as they did the actual removal with the mechanical, she was able to move her entire side. She has some residual speech, but she's now one of our speakers. She actually advocates for the program and is on board with us to help us improve our program and further our program that we have here for strokes at Richmond University Medical Center. So please enjoy your lunch, and he should be here hopefully within the next, he said by 11:45. Yes.
What makes you a candidate for medication?
There are a lot of, when you first come in, we do what we call an NIH scale. Hello, Doctor. This is Dr. Han, one of our neurologists. We do an NIH scale, which is a scale of your functionality. They'll ask you certain things, touching your nose with your arms and stuff like that. They'll check at your comorbidities, basically if you have a history of hypertension, diabetes, whether or not stent things and stuff like that. Yeah, they'll check all that. But actually, the new criteria is there's really not many occlusions or exclusions that actually would warrant that you would not be candidate. They do TPA on patients from anywhere from 18 to over 92. So, and if you're not on an anticoagulant, or if you have a bleeding, in other words, if you're not in we still check your bleeding profiles, but now the new studies show that that should not be a reason not to get the TPA or to get the procedure. So there are a lot of, brain means time, that's the new formatted thing from American Heart Stroke. So time is equal brain, brain equals time, and brain and heart go together. So they monitor you very closely. The neurologist speaks with the neurointerventionist. They do 2 scans. They do a CAT scan without contrast, and then they do what we call a CT angiogram to check and see if there's really an occlusion there, so for both of them. So your age or anything like that and your comorbidities are really not an exclusion. It's on the basis of true evaluation and review of all the tests. And they're done immediately within the first 60 minutes.
And they, I was just going to say, they do it all in 60 minutes?
Yes, sir. We get
within 60
our protocol that we implemented in 2015. We were the first of 2 facilities on Staten Island, which was Georgia CAT scan. So where our CAT scan is, to do your head injury, is right within our emergency room. So when the EMS brings you to the door, the doctor assesses you immediately to make sure your airway is okay, and they take you right into the CAT scan. So we know immediately whether or not what you're having is due to a bleed. If it's not due to a bleed, you become an immediate candidate for the TPA. And that's when they do the blood pressure monitoring, they do extra comorbidities, your blood is drawn, and all that stuff. We have a time element. These are state elements and time elements that have to be dictated to all hospitals that are primary stroke or going for any kind of certification through the state. We have to draw your blood and have it result within 45 minutes. And that's how we facilitate the entire process by having couples.
What's an embolism?
Excuse me?
What is an embolism?
An embolism? Embolism is a clinical name for a clot. It's a clot. It could be in your brain. It could be anywhere in the brain. There are certain areas of the brain that we look at.
A pulmonary.
Pulmonary embolism is totally separate from a thrombolytic embolism. An embolism in your heart is a clot in your heart, in the pulmonary branch that goes in your heart. That's occluding your airway to the rest of it. And it is picked up on what we call a VQ scan. And the DQ scan is actually sees capacity and where it is there, and then they go in and they try to either remove it, or they try, you get medication wise and you're in acute care, you might have to be intubated, but that's separately from the neurological portion of it.
That has nothing to do with the stroke.
Numbing, that's usually that. It can precipitate a stroke because you're not getting the oxygenation to the rest of your body, but it's separate from a diagnosis of stroke.
Let me explain to you. The embolism is a blood clot in the body. When you have skin cut, naturally in humans the blood is clotting and it's stopping. The blood clot outside, and blood is protection. If you're bleeding, have to clot. God made us blood clot, so no more bleeding. But it takes it outside, but inside shouldn't be clot. But our body get aged, so our system getting deteriorated, it's not clotting in our system. So body get confused and or too much fibers inside, fibrin again, and then too much cholesterol make form of the just clot. We call clot, make a mess in our vessel. And so it is a clot, but we call embolism. Outside is clot, but inside we call embolism. It located the lung is a permanent embolism. It located the brain, and then it's a stroke. So brain stroke is dangerous because vessel is so small. So any very fine blood clot can blocking it, and brain cells are dying. The nutrition is blood. Every brain cell we needed it. If few brain cell is dead, and then symptom comes, numbness, weakness, and dizziness, all that. So that brain is more important than blood clot. But our small bodies is not that important. Small blood clot. The small blood clot in the brain is a danger. So that's why and then large vessel means carotid artery, and in the base of the brain, basal brain. So those or blood clot retrieve with machine, small tube going and then take it out, and so it can be pretty big. So before we get into that, the healthy living lifestyle is prevention. So then the TPA we got clot melting, it is 10,000. So it's expensive. So before we get to this, if you prevent exercises, good nutrition, hydration, then you can prevent. But if you have diabetes or cancer, it make a blood clot more in the system. So those people are more careful about the prevention of the smoking, alcohol, cocaine. People use cocaine, it rupture the brain, hemorrhagic stroke. So a good lifestyle can prevent. I had a patient who recovered complete hemiplegia with TPA. In an hour, he was able to move. And then a year later, he came back, same symptoms. He was still drinking and overweight and irregular lifestyle, and he came back. So this is wonderful technology, but people need to think about living life. His living lifestyle is even better than expensive procedure.
So what it is, a part of our program too, is that we go out in the community and do a lot of education. And a lot of our education now has gone more so to our younger community, which is our 18 and 20-year-olds, because not only, like Doc said, the comorbidities, usually if you have any cardiac or neurological deficits, you're on aspirin, and statin now is another one. If you can't tolerate statin, there are also natural things like chia seeds and stuff like that you can use to lower your cholesterol. But they are preventative measures to do that. And the reason why we're reaching out more to our younger population is because there have been incidences now with cannabis that the children are using that it's tainted with K2. And K2 coagulates your blood. So if you're smoking the cannabis and the K2 is in there, we've already had 2 cases where they have had recurrent strokes at young ages less than 25 years of age. So part of our program is really concentrating on going out and doing education. In the fall, we will be rolling out our program to include high schools as well. We are doing senior centers right now, but we're also trying to get to, like I said, younger population, because a lot of that population is also either with elderly grandparents or children of younger ages or babysat by elderly grandparents. And we've all taught them how to call 911 and stuff like that, but also we have to show them that if grandma is talking funny, maybe we should call somebody right away. So we really focus on education. Patient education plays a large component in preventative medicine and any aspect of any disease process. So if you give us a few more minutes, Dr. Kuroshi, please. Oh, there he is. Man of the hour, he's right there.
Give us what? Hey guys, how are you? Well, what can I say after Trisha giving that whole presentation? What can you say? We're just very proud of nursing my stroke unit community. We're just so happy to really be on the cutting edge of stroke treatment right now. That you can really go to any center in the country, and what we're doing here is really on the same level. And that's really the important thing that we can say. And I want our staff to be proud of it, the patients, people in the community to be very proud that we're able to achieve, that we've been able to achieve this. But through a lot of different ways. We have a dedicated stroke unit, and we keep it in the CCU, but it's a stroke unit, for that coronary care unit. We've got a wonderful group of physicians who are doing what's called thrombectomies and interventions where they're going with certain catheters. We'll talk about some pictures of it in order to take out the catheters, take out the clot rather. And we're using the most cutting-edge technique. As I said, whether you have a stroke, God forbid, if a family member or friend has a stroke here, Manhattan, Mayo Clinic, Hopkins, really the most cutting-edge type of things we can get. So I'm going to let them put the slides up, and I just got paid to give you just 1 second, and we'll put it up. Let's put it up.
You want your slides?
Put any slides you like to put up.
All right, so you.
I like pictures, it helps. I'll be back in 1 second. I'll be back in 1
Okay,
second.
put the bridges on.
How do you know if someone has large vessel disease? They've had a big stroke. How do you know if someone's had a big stroke? It's by their deficit. So there's still a beauty in examining the patient, asking the person how they're doing. If someone comes in and can't see, and they can't speak, and their whole side is weak, that's a sign that it's a big stroke. If someone comes in and has just some numbness in their fingertips or numbness in their face, the likelihood it could be a large vessel, but it also could be a small vessel because it's not that much brain is affected. So that's sort of the logic behind it. So the LAM score is what the emergency, what the EMS people do. So when they see someone in the field, they make a determination. There's a point scale based on whether your legs, your arms, your motor strength, your speech is affected. And they add up, they get a point. So each point does that, gets you somewhere. And the more points you have, the worse it is. And the more points that you have, you basically then call into the emergency room and say, okay, we're coming in with somebody who looks like they have a large stroke, and this is just in the field, and we might need to have intervention by both neurology and neurology that does the intervention. The vascular people who come in, basically suck out the clot. We'll talk about thrombectomies a little bit next week. So there's the Los Angeles Motor Scale, that's what the word LAMS is, and it just talks about giving points for someone if they move their arms, their face, their arm grip, and they get a total number. And we also add a speech component to it. Next one. And the NIH stroke scale is this big 30-point scale that we use in the emergency room to try to figure out if someone's having a sizable stroke or not. Again, just trying to see, the concept being the larger the stroke, the more brain is involved, the worse it is, the more likely it's a large vessel, the more likely we can do some intervention. Next. The ideal LVO, large vessel occlusion tool would be, it's easy for EMS to do. And EMS is going to become a pivotal part. I don't know if anyone knows that there's actually a couple of ambulances now in New York City that have a CAT scan. Isn't that amazing? There's actually a CAT scan on the ambulance, the bus we call it. So there's actually a CAT scan there. And they've been doing studies in a lot of places like Los Angeles, which is a little bit more spread out, Cincinnati, a few other cities, where they're giving interventions in the ambulance. And they're actually looking someday to maybe give the clot busters in the ambulance itself. So we're really trying to do much more. They've actually done a couple of proof of concepts. It hasn't worked with some agents that we might think of as a neuroprotective agent. There's some things, magnesium, a couple of that we tried. It didn't work out. Or if you give it them very, very quickly in the field, would it help? That didn't work, but what it did show is that we are able to give these medicines in the field easily and safely. And what's the key word? Telemedicine. Think about what you do on your computer. So I could see a patient while in my office or even here and see what's going on in the field. And with a competent, good EMT, emergency medical technician, we're able to get most of what we need to do. I mean, it's still the old-fashioned, you like to touch the patient, you want to do a few different things. But really, through telemedicine, you can get a lot. Next one. Mechanical thrombectomy, and this is where the times have changed. And times, literally, no pun intended. We have medicines called TPA, and TPA basically is a clot buster. Goes in, it dissolves it. So think about if you had, I think I have a slide up here before, but we used the analogy many times. If you have a clot, or if you have a drain in your house, and it's closed, what are you going to do? First thing, before you call the plumber. Drainer. That's the TPA. It's a clot buster. It dissolves it. Does the drainer work forever? It's not so good. Maybe it opens up a little bit, you get a little drainage, and maybe if you keep on using that drain, what happens, eventually you might have to pull the plumber to actually snake it out. So I'm the guy who gives the Drano, and there's people who do thrombectomies. Dr. Parkins is not here today. Is the group that we brought in, the mechanical thrombectomy group, who comes in, puts a catheter in, and sucks out the clot. So that's basically the guy who's doing the draining, the snaking out of the urine. Now, the time sequence with regard to the TPA or the clot buster, it's about 3 hours. Some of us go up to 4.5 hours. The time sequence with regard to thrombectomies has changed over time. First, they looked at it 6 hours, then they looked at it 9 hours, then they looked at it 14 hours, then at 16 hours. There's actually patients that we can go up to 24 hours after having the onset of symptoms and still show some benefit. And that's by using a CAT scan to see what part of the brain is still viable, is there still areas that are being hypoperfused, meaning not getting enough oxygen, but still very viable tissue. And those people, if we get restored the blood supply, will get a good response, and we oftentimes do. Here's the evolution of a thrombectomy and devices, and here's an interesting story about it. If I had the same lecture 5 years ago, I'd say thrombectomies don't work. Wow, what do you mean? People have been doing it all over the country. Why didn't it work? The devices they had weren't as good. So there's a lot of technical aspect to it. So has anyone ever opened up a bottle of wine? And there's a cork in it. Has anybody tried using a corkscrew? What happens sometimes when you use a corkscrew? Comes out, which is great. What also happens if you don't know what you're doing? So, or if the cork is not as hard, whatever. Pieces go in, right? Those pieces that go in cause strokes, because they go downstream. So that was the problem they had. So now what they came up with, and again, it sounds simple, but it's technically difficult because they're very small devices. They came up with a mechanism where they could put a harpoon into the clot and put almost a bag around it that prevents clots from any sizable pieces. Let's blood get through. It doesn't let considerable pieces go through. So therefore, you can take it out. Anything that breaks off, you have this mesh at the end that will hold it, and you suck out the whole thing. So once we took away those downstream strokes, we saw a lot of benefit. Before we took out the downstream strokes, we didn't see benefit. And that's where the studies changed between, say, 2001, 2010, and then the new big studies that came out in 2014 and 15. And one of the studies I think is always something to remember is called Mr. Clean. That's why it's a way to remember the study. Next one. It's recommended with these neurological examinations if you suspect large vessel occlusion to basically get someone to a hospital who can take care of this. And this is something that's changed over time. And not every hospital can do it. And we're very proud that we can. And time equals brain. What does that mean? Remember, if you think you talk to your kids, and you think when you were a kid, they'd say, well, if you cut off supply to the brain, in 4 minutes your brain is coming. The answer is that's true if you absolutely cut it off. But if you have collaterals and a little bit of blood going through and it's only diminished, you could have hours, even a day or two. So part of the brain could still be very viable. So that's why we do that part. And there's a number that always comes out, and I'm not sure I fully believe it, but every minute that you hypoperfuse or don't give enough blood to the brain, 2 million cells die. Got a lot of brain cells, but 2 million die every minute. It doesn't take much to say in 60 minutes, how many go? That's a lot. And for us who are, who are worried about our brain cells to start with, we don't want to lose 2 million. Next one. Current protocols, again, we're looking for that 15 to 20% of patients who have these large vessel occlusions. The rest of the patients really aren't going to be eligible for it. People with very small strokes, we're not doing it right now. You have to have a sizable deficit, and we use a test called a CAT scan in the hospital. And we use something called a CTA. CTA is a fancy word for a CAT scan with an angiogram. So we give people dye, and we actually can look at the blood vessels in the brain. So if you do a CAT scan, you're getting a picture of the brain. And what's interesting is if you think about an X-ray, and this is all computerized stuff. If you look at an X-ray, anything that's moving, you can't take a picture of. Blood moves. So a CAT scan looks at the parts of the brain that are just there. That's our hemisphere, the lobes, and all those things. The frontal lobe, the parietal lobe, all parts of the brain. There's a way to using a computer to say, okay, everything that's moving, I can take a picture of. And it's a reconstruction that happens with the computer. That you're getting a CTA. So I can actually look at the blood vessels in real time using a dye that goes through there. So there's a way for us to look at the picture and tell whether there's a vessel that's occluded or not. And if a larger vessel that we see is occluded, then we can go in and open it up. Excellent. And these are just the protocols that we talk about. It's that EMS knows it's happening. We mobilize here, neurology, the thrombectomy team, everyone, the nursing team, people who help do the procedure, everyone gets involved. And that's really crucial. Because this is, it sounds like, if you remember the first time when we first started, it had all those thank yous. There's a lot of people involved to do this. It might be just one person there that day, one person in the ER, one person here, one person there. But there's a whole team of 12 or 14 people who come in to do all the mixing of the medicine, to get everything together for the thrombectomy, in addition to the physician who actually pulls out the clot. Excellent. And these are just the protocols. They're just trying to basically tell everyone in the community to get to the hospital early. There was a generation where, what did you do with someone who had a stroke? Put them in the corner. You didn't rush them in. Just have them sit in the waiting room. You put them in the corner, put them in a dark room and say, relax, and we'll see how you do. Did you know that that's what they used to do for heart attack patients too? In the 1950s and 60s, before all these interventions came about, just put them in a dark room in the corner, make them quiet, make them go relax, the pressure will go down and see what happens. And what happened was, if you survived, you did great. But a lot of people didn't survive. And now we're doing so much more intervention. We are looking at people with stroke. We want them in the front of the line of people coming into the hospital. We get calls about people who are having a heart attack before they come into the hospital. So we are really mobilizing for aggressive intervention in order to save that big group. Because that big group, if you take half of the people might not survive or do well, the half that do look great, but that doesn't help us. We want the big group, the big 100% of people, to get as much benefit as we can. These are just references. Next one. Okay. We have a couple of talks on that, but I think that really talks about all the new technology that we have. As most of you know, the left side of the brain predominantly controls the right side of the body. The left side, we use the term dominant and non-dominant hemispheres. Dominant hemisphere, by definition, means your strong side, and also if language is involved. If somebody has problems with the dominant hemisphere, they'll have a language problem. So that's what speech or aphasia or dysphagia means. And what's interesting for the medical students, residents who might be the nurses, and I think we always have this conversation, if someone comes in and has a stroke, and they have aphasia, they can't produce speech, could they understand? Sometimes, there's a different part of the brain that deals with understanding. If someone can't write, can't speak, I gave you an answer, could they write? The answer is no. Could they sign? No. People from Asian cultures are different because they're symbols versus letters. And there's a different kind of language problem. So it's very, very intricate of what happens in the brain. And we've spent generations of time looking at people without really having much in the way of treatment. So what in neurology used to be called the science of diagnosis and adios. We make this brilliant diagnosis and then leave. Neurology is where cardiology was about 20 years ago. Basically, with cardiology in the 60s and 70s, as I said, everybody just looked at them, they did anything. Then they came up with bypass surgeries and other things. Neurology now is getting to that point. Because the catheters had to be different, that the science had to be different, because they couldn't make a mistake, because any mistake could be life-threatening with it. So it's a whole different kind of science, but we've now gotten to the point where neurologists are much more interventional than we were in the past. And that's how science has evolved, because of the technology that we have. And that's basically what we're going to talk about. Trish does a wonderful job running our stroke center. We now are having community programs out for stroke, with support. Our staff, our people, doctors, nurses, medical students, technicians, everyone who's doing everything in the radiology department are all super attuned. I had one of the radiology residents say that they were so interested in this that they want to go into this as their field of expertise. I was very impressed by that. That the idea of us being able to do something. We've had a number of cases that we've done the thrombectomy on, and we started this in April. and we've had some very good success. I mean, yes, there are side effects with this, the risk of bleeding, the risk of other things can occur, infection, but most times we've done well so far, so we're happy. And seeing someone who comes in with a large neurological deficit, with the likelihood of them leaving this hospital or going back home is small, and seeing those patients get better is a mind-boggling thing. That's really why we went into medicine. That's why we want to convince, or make the community feel comfortable, confident is the word, that the hospital that we're at right now, at Richmond University, we're able to give the most safe, the most up-to-date care, the best care for patients with stroke, and not to even have a second thought if someone is having a stroke about coming here. Because right now we are doing the most advanced technologically treatments and interventions that we do. So then I'm going to say thank you. If you guys have any questions, be happy to answer any. How was lunch so far? Yes.
My question is, in an emergency situation, do you have control over what hospital you go to?
The answer is yes and no. EMS really helps make the decision for you. Most people don't have to be up to date. We don't have the whole community of 500,000 people in Staten Island here. EMS knows where to take you to most times. And if they know that if somebody does one procedure and another one doesn't do the other procedure, they will make a choice. Sometimes if you go into the ambulance, you can say my doctor is here, I have a strong preference. And if both hospitals do it, they'll many a time do that. The question comes down to time. You really don't want someone traveling too long.
Right.
And in Staten Island, it's bad, but and I trained at Columbia in Manhattan, there were some issues. If you wanted to go 20 blocks the wrong way or run across town during rush hour, you had to take their advice. Even though you think it's only a mile away, it could take you an hour to get across town, even with an ambulance. Yes.
The Alzheimer and also the dementia can lead to the stroke or not?
Is Alzheimer's disease related to stroke, you said?
Yeah, can lead to the stroke or not have nothing to do?
Interesting, the answer is yes, and
Yeah?
it's a little bit more complicated. People with Alzheimer's disease, that's not because of a stroke, that's a different diagnosis. There are patients with dementia who have dementia because they've had multiple strokes. So there is an overlap with regard to people who've had cognitive problems. So if someone has dementia, which means loss of cognitive functions, memory, orientation, judgment, speech. So it's not just memory. It's not if you forgot where I put my soda down. We're really talking about people with global cognitive impairment, functional decline, problems with driving, people with problems with their finances, things like that. There is one kind of dementia. The most common kind is Alzheimer's disease, which is just a neurodegenerative process of the brain. There is a kind of dementia also related to vascular disease called vascular dementia. The second thing, even a little more advanced, patients with Alzheimer's disease appear to have an inflammatory and vascular component to this. They're not having strokes, but they are predisposed to have strokes. They have an increased risk of various metabolic cardiovascular problems. So people who have hypertension have an increased risk of having Alzheimer's disease. Not stroke related, but there are a number of things that are related. Cholesterol metabolism, sugar metabolism is affected. So there's a whole combination. This is very new in our thinking, that people with Alzheimer's disease actually do have an increased risk of cardiovascular, heart, and brain vascular pathology.
So it's two different things.
Two different diagnoses, but there is a relationship. People with Alzheimer's disease will have an increased risk of having heart attacks and stroke. They're totally different diagnoses.
And have it something to do with the food? You can change your diet or not?
I mean, food is interesting. The diet that everyone's recommending for cardiovascular health is the Mediterranean diet. And what does that mean? It's almost like motherhood and apple pie. Low red meat, low fat, more olive oil, monounsaturated type things, and vegetables and fruit. So I mean, it's sort of what's intuitive to us now. There are different diets that have been looked at. Interestingly enough, people on high salt, who do take high salt diets, have higher inflammation. Salt causes inflammation. So we recommend not to have a high salt diet, Mediterranean diet for prevention of cardiovascular disease. It's controversial whether it might even help with regard to Alzheimer's disease, but Alzheimer's disease is such a common process. About 40% of people at age 85 will have some form of Alzheimer's disease.
Thank you. Also, why with the medication, people who have a dementia, they don't get better? I don't understand that. They stop, they prevent it to get worse. But
what does the
no
medicine do?
medication to prevent, to get better.
Okay. So let me give you an example. If something is broken, giving you a medicine, unless I restore what's broken, you can't make it better. So people with Alzheimer's disease have years and years of having nerve cells die. And it dies because of a degenerative process. There's something in the genes, there's something in the environment, whatever you want to call it, that makes cells die in the brain. And when those cells are gone, they're gone. What we're giving you is a medicine that replaces some of the chemicals that those cells make. I'm not even slowing down the real process. I'm slowing down the process clinically. What do I mean? That usually over a year, one year or two, I can replace the chemicals. And because I'm replacing the chemicals that are diminished from those cells that are gone, we have some stability clinically. But the cells continue to die.
I can answer
But
for
you think it is to prevent it to go and live in a different part of the world? Like some people move out of the United States, they say Europe is better to live it for such a disease. That's true or not?
I don't believe that living in different places really makes a big difference. I've seen the commercial about the yogurt and people in Ukraine who live to be 150. I mean, we've seen those kind of things, but it's unusual. I mean, normal healthy lifestyle. Of course, I mean, there are environmental factors to it, stress factors to it, but there's really no place in the world that doesn't have most of these diseases. Yes, Dr.
I can answer for your question. In Alzheimer's disease, the medication doesn't cure, right? It's a medication. The medication, Alzheimer's disease is all 4-5 different reasons for it, but current medications what available is related with acetylcholine. Acetylcholine is amino acid, increase our memory. So when we get older, the substance, the area, substance innominata, that area is acetylcholine depleted. So our memory declines, everybody. But the dementia, people is more faster declining. So the medication are available, whatever left in acetylcholine in our system, blocking breakdown and stay longer to function. The Aricept, Namenda are different. Aricept, excellent patch, Reminil, those are blocking the enzyme to break down acetylcholine. So our system, any amino acid come in the system, quickly break down. So it doesn't last long. The blocking the enzyme, not breaking down. So when we get older, we make less acetylcholine. So the Alzheimer's patient studying less and getting zero, in their case, nothing to block it, nothing to break down, is no longer effective. This current medicine, Aricept, Namenda, Reminil, is not effective. It's not preventing. What you have, try to preserve. That one theory, acetylcholine. Another theory is amyloid plaque. So somehow in brain, the amino acid 44 is not melting. A smaller amino acid 40 is dissolved. We dissolved our system. But in Alzheimer's, heavy amino acid deposit conglomerated and big cloud as killing normal brain cell. That's amyloid theory. So then there is another theory, tau theory, is tau protein is combining with phosphate. The phosphate in tau protein has to be one tau protein, one phosphate combining. In the Alzheimer's diseases, this tau protein has many phosphates. One man, many women, and the man dies. So the tau protein is the building in nutrition. Neuron 2 is bridge. Neuron 2 getting nutrition. So there is the break down the wall, nutrition cannot get in there. And so there's neuronal tangulation, the neuron damages. So that's another Alzheimer's theory. In that case, there's no medication yet. They're trying to develop medicine. Downstate, they're working on a develop medicine blocking the phosphate attaching to tau protein. So that's another theory. And the lipoprotein theory is only dementia. The lipoprotein is our nutritional transmission protein, nutritional protein. So then in genetic diseases. the early dementia, the Alzheimer's type, is kind of, they have problem with lipoprotein. And another one is congenital, presenilin 1, presenilin 2, they're congenital neurodegenerative disease, autosomal dominant 1 and 2 deficit, genetic disease. Alzheimer's was genetic disease. Some people
I
get-
understand, but which one is worse? Alzheimer's or dementia?
I'm sorry?
The Alzheimer's is worse or dementia? Which one is?
Alzheimer's is dementia. Alzheimer's is the doctor in German, Dr. Alzheimer, who identified neurofiber tangle in the German doctor. So they put the name Alzheimer's disease, dementia. So that's called dementia is dementia. So Alzheimer's, that type, not only neurofiber tangle, tau protein died, there's other reasons, amyloid deficit, tau protein, presenilin, all 4 different theories. So, but the current medications right now available is acetylcholine theory, blocking degradation of
I
acetylcholine.
understand
So
that,
there's
but you
nothing
think
to
in
work.
the future there will be better medication for
Yes, there will always be better medicine. They're looking for things. Sad to say, over the last 15 years, they've looked for different medicines for Alzheimer's disease.
But
And they've all failed. They haven't shown benefit. So they're working on new treatments, and some of the treatments are various new chemicals that basically take out some of the bad things that are caused by Alzheimer's disease. I'm sorry, yes.
But this medication is it to get back the memory or just to
Right now, we don't have a medicine that gets people better. We don't have a lot of medicine for many disease processes that get people better. We have medicines that try to slow down the process, and even with that kind of a case, we just are replacing the chemicals that are diminished. The cells are continuing to die.
So increasing acetylcholine.
Yes, ma'am. We're not
Yes,
going
I'd like to get back to the stroke, if you don't mind.
Sure.
If someone is on a blood thinner like Eliquis, all your procedures available to that patient?
Interesting enough, yes and no. Some of them are, some are not. Eliquis is a blood thinner that we use for people who have atrial fibrillation. And it's a strong blood thinner, and it can cause some bleeding. So what happens is, if someone comes into the hospital who's on Eliquis and has a stroke, which is somewhat also atypical because that's a very potent blood thinner, but if it happens, we can't use the clot buster because of the bleeding problem for that patient. But they can do a thrombectomy. Because they can go in and actually pull out the clot. I can't give you a medicine intravenously that goes throughout your body because the risk of bleeding will be very high. So there are certain things we can do and there's certain things we can't. So remember, there's 2 parts to it. There's the Drano part and there's the snaking out. You can't, if you're on Eliquis, I can't give you the Drano part, but you can snake it out.
So would you recommend maybe wearing a bracelet or something that says?
Everybody who comes in, we find out what medicines they're taking before we
Yeah,
give
but
any
if they
treatment.
can't speak,
Understood. Then there's family members. You're absolutely right. But one of the wonderful things that has happened recently is the electronic record with regard to pharmacies. If we can figure out which pharmacy you've been to, the pharmacy will have it electronically. That's been a major advance. It's not like, unless somebody goes to 20 pharmacies and doesn't know the name. Yes, is it possible if someone comes in, we have patients who come in who are, quote, Jane Doe or John Doe. They don't even know their name. They're coming in a coma until they wake up, until they're treated. So it's hard to know. Yes, is it wise to have in your wallet what the name of your pharmacy is and what medicine you're taking? Absolutely.
What we do is in the community, we take a 3x5 card and put your medications and your name and your date of birth on the card and just put it in your wallet and keep it on your person. Because that's, and then, right, if it's like, basically if you have it on your person or you're with a family member, they don't know, and the craziness and the chaos of being in the emergency room and getting everything done, we'll ask, the first thing the admitting clerk will come up to you is what's your name or date of birth. If you've been here, we can access immediately, we have electronic availability to check the notes.
Couldn't one hospital contact the other
That's actually
hospitals
one of
in
the
the area and
That's actually a
say,
difficult aspect. I'll tell you, one of the craziest things and one of the things that I have very personal objection to is I'm personally upset that when the electronic medical record came out, that the government wasn't the one who did it, rather like they do in the Veterans Association. The VA, it's all one. Basically, different companies, almost for profit, basically made different electronic medical records. So different hospitals have different doctors have different relationships. And since the day this came out under Obamacare a number of years ago, I thought, why don't you have one system? It's not a free market system, but it's better for the patients that we have one system that can talk to each other. They can't speak to each other. There are some that can, if they give you the codes, but I couldn't pull Walter Reed and say, let me look at the president's blood work for this week. It just doesn't work that way. Yes.
If you request going to a hospital in Manhattan
Yes.
and you're having a stroke, they won't take you there.
I think the risk of the time element, really the time element is the issue.
Okay, that's number one. And number two, she spoke about a drug, if you can't take statins, you have high cholesterol. There's another thing you could get. My doctor said there's something, but it's too expensive.
Okay, there are other therapies.
What are those?
I mean, I'll talk about it briefly. I mean, there's a monoclonal antibody. There's a medicine that directly goes against part of the cholesterol production and does it. It's an expensive new medicine that's out there called Latathia. There's a number of agents out there that can work for it. There's even some older medicines that they sometimes use for it. They're not as potent as these statins, but people who can't take them, it's medicine called Zetia. There's other issues.
What are they covered?
Again,
I think they give medicine that's $800 a month. With my coverage, my deductible is $800 a month. That's one medicine.
The answer is it's all based on the company, and that's why that's what's going on right now.
Ridiculous.
You're absolutely right. So guys, thank you so much for coming today.
Thank you.
Enjoy lunch. It was a pleasure.
Thank you. Monica, ci domandavo, sono ancora a termine.